Hello, everyone. Welcome to this webinar about the results of our systematic review in the framework of clinical practice guidelines. So just to set the framework we are working on, as you can remember, we have a systematic review trying to answer 7 questions. The 7 questions you have listed below in the frame of GradePro GDT, which is the software we are using to develop this clinical practice guideline. So these are the 7 questions we would like to answer with our systematic review. So related to these questions, we have designed or defined 28 outcomes. These outcomes were proposed by all the experts from the ERN. And finally, we have extracted data only for 19 because some of them were not reported in any of the studies. So the studies we have identified come from this flow chart. So at the very beginning, we had 57,044 non-duplicate citations. From this number of registries, we decide to include by a peer review system 4,020 articles. After that, we have included 195 articles, and during the process of data extraction, we have identified that these 195 articles belongs to 129 studies. So from those studies, you can see in the picture, we have only 11 randomized controlled trials, 4 non-randomized controlled trials, 11 core studies, 5 case control studies, 13 prospective cohorts, and 85 retrospective studies. So the first lesson to take is that most of the evidence about the immunosuppression is coming from retrospective studies. So more than 50% of the studies are retrospective. So from this amount of studies, we have selected only randomized controlled trials to make the evidence tables, because the grade system admits only either observational studies of randomized controlled trials, but we cannot mix them. So we are planning to extract data and elaborate the evidence tables from the randomized controlled trials, and trying to use the rest of the information coming from the other type of studies for the panel discussions. So these are the 11 articles, which are 10 studies. We have identified on the studies where we have extracted the data. As you can see, the interventions are completely different. There are similar interventions, but not identical interventions. So in order to identify which strategy is the strategy followed by the authors in each of the studies, we did strategy consultation to 25 experts from the ERN. Sadly, only 7 replies. And by those replies, we decide to identify the strategies for each of the studies. So you can see here on the far right, 2 columns. One is the column of the organ, and the other one is the column of the strategy. So as you can see, the organ mainly is kidney with 7 studies, followed by liver with 2 studies, and only 1 for hematopoietic stem cell transplantation. That means that most of the organs we have in our ERN have no randomized controlled trials assessing the immunosuppression strategies. Probably there are studies not randomized dealing with that, but not clinical studies. In relation to the outcomes, you can see here that the most reported outcome, over 50%, are acute graft rejection, graft loss, patient survival, growth, and kidney graft function. So we were expecting that patient survival, acute graft rejection, and graft loss were the most reported. But to be fair, we thought that probably more information about the graft versus host disease, PTLD, and some kind of infections would be much more reported. but well, it's not bad at all. If we split this outcome reported by organ, we can see that obviously, because kidney is the most represented organ in this list of randomized controlled trials, they have much more representation within each of the outcomes. As you can see, there are 3 outcomes that are only reported um, by studies of hematopoietic stem cell transplantation, as are acute graft versus host disease, chronic graft versus host disease, and graft function. And the rest of the outcomes are more or less equally represented in each of the outcomes in the very similar way as they are in the distribution of organs. So in terms of the synthesis of these outcomes, a potential meta-analysis by strategy, and I say potential because probably due to the heterogeneity within each strategy in terms of interventions, probably we cannot do meta-analysis by strategy. But anyway, this will be sent to the panel in terms of discussion. So the first strategy is kidney withdrawal. There are 3 studies, 4 articles, and you have there the list of outcomes that could be potentially meta-analyzed within this strategy. In yellow, you have kidney conversion, which are reported by 3 studies. And you have also the list of outcomes. And again, in liver conversion, only 2 studies and the list of outcomes. I have no mention before about the year of publication of each of the studies, but we have only 2 studies in the last 10 years, and we have 4 studies from the last century. So probably the panel need to say something about that in terms of if the studies from the last century are representative of any strategy in our hospitals nowadays. And probably we have to deal with that. So in terms of meta-analysis by outcome, I'm going to show you which meta-analysis we have identified we can do, because even when we identify potential meta-analysis, we have to check that the outcomes are reported at the same timeline and the same time cut. So for example, acute graft rejection you have here. If you see down in the slide, you can see that not all the studies can be meta-analyzed at all time points. For example, for kidney withdrawal, we have three studies, but only 2, the 3 studies only can meta-analyze data for 12 months. For 6 months and 24 months, only 2 studies can be meta-analyzed. And this happens also in some other outcomes. So this outcome is very well reported. I mean, it's just to say the number of acute graft rejection over the number of people alive at this time point. Also, we have some comments from a recent paper trying to not use acute graft rejection, but other definition. So probably we need to change that. Professor Lorenzo tell us that probably we need to deal with acute and chronic graft rejection in order to change the name and also to extract again the data, basically due to biopsy-based rejections and cell-mediated rejections. So the next one is high blood pressure, which is well reported in terms of number of people with high blood pressure. But again, the definitions are not very homogeneous, so probably this potential meta-analysis cannot be done. Again, we will send all the information to the panel, and the panel will decide, but probably we cannot do meta-analysis. As you can see here, we can only meta-analyze for liver conversion, so only Alvarez and Kelly. Graft loss is well reported, but the issue is that most of the studies, they have no graft loss. That means that we cannot meta-analyze studies with 0 cases. Well, indeed we can, because we can say instead of 0, 0.1, and which will not do much more noise into the final analysis. But as you can see, there are only a few studies with numbers, and also there are big differences. For example, in the study of Kelly, we have 7 cases of graft loss in one group and 14 in the other group. And if you see tacrolimus also in Tonshoff, you see 0 cases. Either they are not the same organ, but sounds strange. So again, this will be sent to them to the panel to decide. The next one is bacterial infection. Here, the issue is reported in different way. That is, for example, Alvarez is reported in number of bacterial infections. This is like a dichotomous variable. But for example, Hawker in the 3 studies, or in the 2 randomized controlled trial and the last paper, which is not a randomized controlled trial, they give a mean number of events per patient, which we cannot be a meta-analyzed straightforward. So probably we need to decide if we want to transform these figures into cases or whatever. In terms of cytomegalovirus infection, it's very well reported. Definitions are quite good, I mean, and homogeneous. So probably here we can go ahead with the meta-analysis between Tonshoff and Breuer. Here the issue is one study is from 1987 and the other one is from the last year. So, well, I don't know if this will be a problem. Probably not, because Tonshoff have more or less the same rate that Breuer. In relation to other infections here, as you can imagine, we have a lot of heterogeneity coming from the definition of other infections. Other infections, for example, in Hooker, it's based on viral infections. But if you go to Breuer, for example, it's only labial herpes, which is a virus, but probably we cannot meta-analyze. I don't know. Again, the panel will decide. And Tonshoff and Alvarez, for example, they have other infections, and they include viral infections only, but different from the study from Hawker. So, well, again, it depends on how much impact some types of infections in the global number. So all this information will be included in the evidence tables, which will be sent to the panel. In terms of patient survival, this is, I think, the best reported outcome. But again, we have 0 or only a few events in all cases. We can do a meta-analysis, but probably it's going to be 0. So there will be no sense on doing that meta-analysis, but we have to declare that. The only study that have reported treatment-related mortality only based on incidence is Lanino, which is the only study on hematopoietic stem cell transplantation. So again, we can calculate from this incidence the number of people dead, but the issue is here is reported as a cumulative incidence with a standard deviation. So we need to with a standard error. So we have to deal with that. And we have the study from Breuer, 1992, which is a special study. The randomization here was done 14 months after transplantation. That means that all the people suffering any of the outcomes before the 14th month is not included in the study. So probably here we are overrepresenting survival or graft survival or something like that. So we are going to make an appointment on that to be sent to the panel in order to say we are probably losing all the information here because it's very biased, as they have included only people surviving the month 14th. The next one is PTLD. So again, well reported, but again with a few cases. So probably cannot be meta-analyzed. If you see we are going to meta-analyze, or the potential meta-analysis is Alvarez and Kelly. Alvarez, they have 1 case in each of the arms, and Kelly, they have 5 and 1. So difference is very high. So probably the meta-analysis is going to give all the weight to Kelly because the number of studies, and probably we are going to have some kind of heterogeneity. In relation to kidney function, well, it's very well reported. The only issue here is sometimes is reported as GFR and sometimes as inulin clearance. That means that, well, we need to go ahead with a deep evaluation of definitions because not always inulin clearance is similar to GFR. In relation to growth, it's very well reported in general. All the studies report at least height, which is fine. Some of them are reporting also weight. As you can see, Kelly, for example, or Tonskov, which is reporting the three areas, height, weight, and BMI, is reported in the same way. So hopefully this is going to be a very good meta-analysis, sorry, and it's going to be very, very interesting. Difference is, well, there are some kind of differences between organs. Some of the studies, they are reporting no difference or very minor difference in height. Some of them are reporting big difference. So, well, I think it's going to be very, very interesting, the meta-analysis about growth. And finally, kidney graft function, because kidney is the most represented organ in this systematic review. We have put a lot of attention extracting data. So here the main issue is that some of the studies are reporting mean and standard deviation of GFR only in some time points. For example, if you see in the top of the slide, Grenda 2010, we have the GFR at 6 months reported as mean and standard deviation, but for 12 and 14 months is reported as median and EQR. That means that it's not straightforward to meta-analyze this data with the mean coming from other studies. So this is the first thing. So probably we need to convert median and EQR in some kind of mean and standard deviation, which is not the best way, but well, I think is fair. Another issue here is again the GFR and other similar outcomes. For example, the creatinine clearance or inulin clearance, which is reported in some studies. So again, here we need to send an appointment to the panel to keep an eye on that and decide if they want to meta-analyze, or if the panel decide this is going to be a very noisy meta-analysis, we can avoid it. So summarizing, the synthesis of evidence depends on panel decisions about the heterogeneity within the strategies. In my opinion, the most probable scenario is that instead of answering 7 questions as were frameworked in InGrade, the panel probably have to deal with 10 questions, which, to be fair, is not a big deal. I mean, instead of 7 questions, we have to deal with 10 questions. But the issue is that if we answer 10 questions very particular, based on particular interventions, the guideline only can give recommendation on that. If the panel decide to go ahead with the meta-analysis by strategy, we can answer the 7 questions, and the questions are much more inclusive. Well, I think it's a matter of think about that. The easiest thing and the safe thing probably is to answer 10 questions because it's the information we have. But again, because we have a lot of studies, retrospective studies, giving a lot of information, probably all this information can help to decide. In terms of next step, we will report all the evidence in the tables, in the evidence tables, based on great progeny to the panel. We will wait any amendments suggested by the panel. We will deliver a final version to the panel, including all the meta-analysis they decide to go ahead with. We will deliver the summary of findings tables, and the panel will elaborate the recommendation using the information provided by those 118 remaining studies, not included because they are not randomized control trial. The estimated timeline is to have this ready by the end of 2020. I mean, to have at least the final recommendations, probably not the guideline fully written, but at least all the proposal and recommendations. So, well, I think that's it. So if you have any question or any issue you want to discuss.
Hello, Carlos.
Yep.
Well, I think that's a little bit frustrating. All this effort for the results of the evidences. And I think that at the end it will be difficult to make a quantitative or to have a quantitative results of this effort. So most of the decisions should have to be taken by the panel.
Yeah.
The other thing is that obviously you mix or cross the strategies and the outcomes. I mean the different treatment strategies or immunosuppression strategies and the outcomes and the conversion of withdrawal. The number of studies for each of these combination at the end will be quite short, or maybe just one.
Yeah, probably the most of the most of the studies, including what meta-analysis, will be 3.
Yeah.
Yeah.
And the other question is that maybe we should think about to split or separate the one strategy that will be the reduction of corticosteroids. Just the reduction of the dose of the corticosteroids or the withdrawal of the corticosteroids.
Yeah.
Because it's quite frequent, and because there are some studies evaluating just this intervention.
Yeah, agree.
And,
yeah, well,
this is we maybe it would be fine to separate or to split the other types of minimization or conversion by just the corticosteroids reduction.
Yeah, probably this is one of the ideas I have in mind, but again, I think this will be or need to be proposed to the panel, and obviously the panel of experts will decide.
Yeah, obviously.
I agree with you. Yeah.
Okay, I'm aside. That's all.
Okay, thank you, Antonio. Okay, so if there's no more questions, so thank you for your attendance and enjoy the summer. Bye.
Bye.